I have no disclosure. So just I'd like to introduce my hospital is across the Tokyo area, Saitama Medical University, just opened 2007. So gender is known as one of the risk factors of post-operative complication, especially anastomotic leakage after proctectomy. The purpose of this study is to assess difference of short-term results between male and female for laparoscopic proctectomy. Design of this study is multi-center, prospective, one-armed study. Patient clinical stage 0 and 1 rectal cancer excluding rectal sigmoid. And 490 eligible patients were recruited since 2008 to 2010. Here is the patient characteristics. Age is same, 59 age. Yeah, and body mass index is significantly more in male, and previous abdominal surgery is significantly more in female. AS score is more in male, but all cases score 1 and 2. Location of the cancer is almost same in both groups. Here's the operative results. Procedure is almost same in both groups, but if we look at the intersphincteric resection, male is 52 and female is 25. This is significantly different. We can understand male is sometimes difficult to rectal transection and anastomosis, so surgeon is change the procedure. And operative time is significantly different. Male is 30 minutes longer than the female. But blood loss count is no difference in both groups, 35 and 20. And length of incision is almost same in both groups. Conversion rate in male is 1.8% and female is 1.5%. All of the cases clinical stage 0 and 1, most of the cancer is very small, so this is the reason why conversion rate is very small. And left choric artery is almost 80% is preserved in both groups. Most of Japanese surgeons' favorite is preserving left choric artery. And approaches, most of all cases are medial to lateral approach in both groups. Here's the intraoperative complications. So organ injury is 5 in male and 7 in female, also very small number. Small intestine is common in male and vagina is common in females. And difficulty of the rectal transection and difficulty of anastomosis, most of the cases in male, just one case is in female. Here's the pathological data. Size of tumor, proximal and distal resection margin is almost same in both groups. Lymph node harvest is significantly different. Females more than male, but all of the case, both of the group, 15 or more lymph node harvest in both groups. And T factor and N factor is in this size. Clinical stage 0 and 1 is this patient series, but pathologically T3 or T4 is about 20%, and lymph node positive patient is about 30% in both groups. Here's the post-operative results. Time to plate or bowel movement and liquid and solid food intake is same in both groups. But post-operative hospital stays 1 day longer in male groups. Here, this is significantly different. And this is a key slide of this presentation, morbidity and mortality of both groups. There is no mortality in both groups, and morbidity, patients' number of the morbidity is significantly more in male group. Anastomotic leakage, wound infection, and post-operative illness, these 3 big complications significantly more in male groups. So, ladies and gentlemen, I'd like to conclude male was a risk factor of post-operative complications, especially anastomotic leak, wound complication, and illness in laparoscopic rectal cancer resection. Thank you for attention.
This paper is now open for discussion. Could you identify your name and where you come from during when you give the questions? Okay, really questions?
Why do you think it is that, I mean, I know what your conclusion is that, male gender is the factor that potentially leads to these increased complications, but what is it about the male gender that you think leads to it? Is it a technical issue? Certainly in a bigger BMI patient, a narrow pelvis and a deep pelvis, may be a technical reason why, but, and I know you have statistical significance between your BMIs, but certainly for those of us on this side of the world, BMIs of 21 and 23, I wish all my patients had those, let alone, that you're thinking that that's higher. So what's the reason?
Yeah, that's a good question, but there are a lot of reports. Male is a risk factor of the many complications. And one of the reasons is that BMI is usually more than a female. That is one of the reasons. And also, male pelvis is very narrow. And also, visceral fat is more in male. So it's not only the BMI is a problem. So visceral fat and narrow pelvis. And also, I don't know why female is longer life expectancy, more male. That's I don't know what one of the reasons. So, but male factor is a reason why this result, I think.
Yes. Have you done any multivariate analysis on the complications so that the BMI can be controlled and other preoperative factor can be controlled?
Actually, we did anastomotic leakage after double stapling technique, BMI and gender and another factor, and we did analysis of the multi, and only the male is a risk factor of the anastomotic leakage from this study.
Did you also look at what percentage of patients who had leaks had diverting stomas? Because I know you didn't use a diverting stoma in many of the patients who had an anterior resection, but you used it in a lot more in the ones who had an intersphincteric resection. So these leaks are all clinical, number one, is my first question. And second off, how many patients who had a leak were actually diverted before, prior to that, or were all the leaks in patients who didn't have fecal diversion at the time of surgery?
Okay, first of all, second question, diverting stoma, about 60 to 70% of the case has made protective stoma because stage 0 and 1 rectal cancer, there's no radiation, chemo radiation before operation. And what is the number one question?
Well, just were diverting stomas protective against leaks? So you had, 27, I think, leaks in the anterior resection group. How many of those patients were diverted versus not diverted?
Oh, I don't have precise data, but usually depends on the hospital and the institute. Some surgeons like to make protective stoma, including me, but other hospital they don't make. So I think there is no difference from this study because 61 institutes joined this. So it is not so big number from the one hospital.
Maybe the last question. So previous studies showed that the number of fires affect the leakage rate. Have you analyzed the number of fires? Is there any difference in the male or the female? I mean the transverse stapler to staple the rectum. Is there any difference in the number of fires of stapler when you are performing the anterior resection in male and female?
You mean the number of stapler?
Yes.
Oh, that's one of the risk factors. But from this study, 3 or 4 and 5 stapler is only one cases, but no leakage. The 3 stapler is a little bit higher, about 15%. And 1 or 2 is less than 10, around 5%. So 3 or more stapler is, I think, a little bit dangerous because the staple line is very complicated and then some ischemic change has happened.
Okay, thank you.
Thank you.
Thank you.